Welcome back, Dr. Welly here. Today we are diving into the high-yield principles of fracture management, focusing on the core concepts you'll need for your intermediate orthopedic exams. We start with the golden rule, the 4 AO principles. These are frequently tested and form the foundation of everything we do. First, anatomical reduction, essential for intra-articular fractures. Second, stable fixation, which can be absolute or relative depending on the fracture pattern. Third, the preservation of blood supply by respecting soft tissues. And finally, early mobilization to reduce stiffness and long-term complications. When a patient arrives, assessment begins with ATLS. Always manage airway, breathing, circulation, disability, and exposure before focusing on the limb. When examining the limb, look for open fractures, neurovascular injury, and compartment syndrome. Documentation is critical both before and after any reduction. Memorize the 5 goals using the RARRR mnemonic. Reduce, align, retain reduction, rehabilitate, and restore function. Understand the difference between stability types. Absolute stability leads to primary healing with no callus, while relative stability allows controlled motion and secondary healing. Most fractures heal by secondary healing. This involves 5 stages: hematoma, inflammation, soft callus, hard callus, and finally, remodeling. Healing is affected by local factors like blood supply and infection, as well as systemic factors, most notably smoking, diabetes, and malnutrition. Open fractures are extremely high yield. We use the Gustilo-Anderson classification to grade the severity of the soft tissue injury and contamination. Management follows 6 steps: ATLS, immediate antibiotics, tetanus prophylaxis, sterile dressing, splinting, and urgent surgical debridement. Compartment syndrome is a surgical emergency. The earliest and most sensitive sign is pain out of proportion and pain on passive stretch. Watch for the 6 Ps. Remember, pulselessness is a late sign. If you suspect it, proceed directly to emergency fasciotomy. Fat embolism syndrome often follows femur or pelvic fractures. Look for the classic triad of respiratory distress, neurological symptoms, and a petechial rash. Non-union can be hypertrophic, meaning good biology but poor stability, or atrophic, which indicates poor blood supply and requires bone grafting. In pelvic fractures, the immediate cause of death is usually hemorrhage. Management focuses on the pelvic binder and rapid resuscitation. Memorize these core classifications: Gustilo-Anderson for open fractures, Garden for femoral necks, and Weber for ankle fractures. They are exam staples. To summarize, pain on passive stretch is compartment syndrome. Articular fractures need anatomical reduction, and most fractures heal by secondary healing with callus. That covers the essentials for your orthopedic intermediate exams. Focus on these principles and you'll be well prepared. Good luck.